So thanks for coming. This is the beginning of our Operations and Strategy Seminar Series for this year. We're going to bring in some speakers every month, some experts in the area of clinical service lines to talk to you about a variety of related issues. The faculty got together and decided that we were going to use the theme of clinical service lines this year. And that will be the theme that will continue throughout the academic year. And as I said, we're going to take a topic per month. We're going to bring in folks on the clinical side. We're going to bring in folks on the supply chain side. We're going to bring in folks on the operations side. So the whole theme of this next seminar series, Operations Seminar Series, will be clinical service lines. It's my pleasure to kick off the season. So I'm going to talk to you tonight about clinical service lines, the what, the how, but most of all, the why. And the what and how I think will be important to you. But I think what I'd like you to listen for tonight is the why. This is a real trend out there. I'm going to share with you some perspectives from the field, and I'm going to share with you some survey results I did together with one of our grads, Don Wegmiller. We went and surveyed I think we surveyed 47 health systems around the United States and asked them questions about clinical service lines. He and I published a brief article on that, and I've distilled that tonight to sort of kick off this whole notion of what are clinical service lines. As I said, I'm going to talk about the how, I'm going to talk about the what, but I want you, as I said, to listen for the why. So that's what we're going to do. This is really informal, so while I'm certainly need to deliver a lot of content to you, please ask questions along the way, and it'll be my job to sort of manage the time here tonight. I think we can do this in 90 minutes or less, but feel free to ask questions as we go. So that's what we're about to do tonight, and thanks again for coming. It's nice to see such a good turnout. So when Don and I went out and asked the question of about about clinical service lines to 47 health systems in the United States, 85% of them said we were already in the business of clinical service line development as a strategy, or they were about to move into it. So this is not just simply a fad in the marketplace today. So I'm going to take you into the what and the how, but as I said, I want you to pay attention to the why, because I think that's important here. Yes?
Do you actually have the breakdown of which ones had already established and which ones were?
I do, but not for tonight, but thanks. So for tonight, what is a clinical service line? You're going to hear the term bandied about in the marketplace, and it's one of those terms that everybody seems to have a common definition for, but very few do. So I'm going to provide kind of a table setter tonight for you. What is a clinical service line? And for at least tonight, we'll use this as the definition. So for purposes of tonight, a clinical service line is a grouping of patient services and programs dedicated to an identified constellation of clinical diagnoses. Could be cardiovascular, it could be orthopedic, it could be neurovascular, it could be women's services, designed, directed, and managed to produce a coordinated, unified, and standardized course of evidence-based best practice treatments and patient experiences across a system of care. And that's a fundamental issue for tonight, across a system of care. And I'll talk to you about what that means. So if you think about it, I'm sure you've heard about health systems with their clinical service lines, their cardiovascular services, the orthopedic services, the neurovascular, cancer care. And actually cancer care is projected to supplant cardiovascular services, is probably the #1 clinical service line of health systems over the next several years. If you look back over the last even 2 decades, a greater portion of health system revenue and clinical activity has been dedicated to cardiovascular services. There are a number of experts in the field that think that's going to switch, and the #1 service line in terms of activity, clinical revenue, and related resources use will probably be cancer care. And you really don't have to go farther than the epidemiology of the population to figure that out. When you take a look at the epidemiology of cardiovascular services in the United States, actually the prevalence and the incidence has been flattening. What's still on the rise, and it's probably due mostly to lifestyle issues, is cancer as an epidemiologic risk. So consequently, you're going to see, and we will see, a number of health systems ginning up their their cancer care service lines. There'd be a lot of investments in that area. So what are the characteristics and some of the attributes of these clinical service line strategies? The patient can expect delivery on a health system promise of a well-coordinated course of care over a variety of locations from a health system. You don't have to go very far back to see how health systems were created in the United States, and many of them were created as an aggregation of hospitals, hospital mergers, what we would call horizontal kind of merger strategies. And interestingly, as health systems formed from hospital mergers, they pretty much had a strategy of whatever you wanted to do at your own location is up to you. In quotes, you know best how to provide services to your patients. Well, as you might expect, that created a delivery system that followed the design. Wherever you go in the system, wherever you get cardiovascular care, neurovascular care, that's how it's done there. As health systems have progressed to promote more of a brand strategy, a Health Partners or an Allina or a Mayo, the promise of that brand is really a consistency of care from standardized evidence-based best practices across that system, irrespective of where you enter that system. And if you think about it, it makes sense. If your family member, if your family member is in a marketplace where there are health systems, let's say you're in South Dakota. There's 3 major health systems in South Dakota. There's Sanford, there's the Avera Health System, and there is the Rapid City Regional Health System. All of them are competing for markets, and they all have a brand strategy out there. And they all have programs. Come to our cardiovascular program, come to our cancer care program, come to our orthopedic program. What they're doing with that strategy is they're making a brand promise that you're going to be cared for by a system of care. You ought to be able to enter that system by any door, anywhere geographically, and expect a standardized approach to care. It's the brand promise. The disingenuous approach to that would be, sure, we're a system of care, but you know, depending on where you enter that system, they may have a different approach to this. For those of you in my integrated system class, we talk about this, and we will continue to talk about this concept, that health systems are holding themselves out with a brand promise, and that brand promise is a best way to a particular constellation of diagnoses, whether again it's cardiovascular or orthopedic. And I ought to be able to take my wife or my child into your system through any door, anywhere geographically, and expect to be taken into that system of care. I don't want to be 6 months into the care process and figure out that something doesn't feel right, have me go to somebody at the local hospital and say, it doesn't feel like I'm getting this system of care approach, and then have the hospital administrator say, oh yeah, by the way, your doctor is an independent physician in the system, and however he or she decides to treat you is kind of up to them. I would be asking, how did I get that? That's not what you promised me. I've been looking at your billboards, I've been listening to your TV commercials, and you promised me a brand. You promised me a best approach to cardiovascular services, and now you're telling me I got, for some luck of the draw, I got an independent physician who's not part of your system, and therefore he or she is pursuing care on a different path. He or she may be right, but it's not what you promised me. So as health systems are beginning to compete with clinical service lines, one of the important attributes or characteristics of that is the ability to enter that system from any geographic door, anywhere in that system, and expect to be taken care of by a system of care. There are typically pathways for diagnostic and treatment protocols that are consistent, and they're predictable across sites. This is not cookbook medicine. That doesn't mean everybody is treated the same. But there is a promise and an expectation of a pattern of care or a system of care. Patients are engaged in that care process across the system, regardless of site, and there are methods for measuring and evaluating clinical progress on a uniform basis across sites. One of the attributes or characteristics of a good clinical service line within an integrated health system is that they will operate from the same balanced scorecard, and you can ask for that, and they should have it. It will have typically 4 categories attached to it. It will be operations, statistics, volumes, access, that sort of thing, clinical outcomes, access standards, and financial and operating results. So the methods for measuring progress or a patient's progress through that clinical service line is usually measured the same way across sites. Costs per course of treatment are managed within acceptable and predictable ranges. You've heard the term, or should have heard the term by now, total cost of care. And total cost of care is a pretty different way of looking at things than we looked at it years ago. Hospitals in particular were really set up on a clinical and business model of cross-sectional events. The heart attack, the baby being born, the surgery being done, the hip being replaced. So if you look at the business models and the financial models and even the clinical models of many hospitals over time, they were really set up on the cross-sectional event. As health reform has taken over, as strategies have moved more into population health strategies, the real concern is more total cost of care for a particular diagnostic category of folk over time. So it's much more of a horizontal over time strategy than it is a vertical event strategy. You know, if you talk to many chief financial officers of hospitals only a few years ago, they would have told you, I don't want any heart failure patients being admitted to our hospital because we actually lose money on those and it's really not a profitable area. If you're in the business of managing care over time through a service line, you would want all those people with heart failure affiliated with your system, and you would be managing them over time. Much more of a horizontal strategy, both clinical and business, as opposed to a vertical strategy, which many hospitals, the more traditional hospitals, were set up on for years. So you're looking at not only unit costs per case, did we provide a particular service efficiently at an affordable cost, but you're also looking for managing those total cost of care for a diagnostic category over time. If you look at Health Partners, for example, they have been one of the leaders, and they've been on the leading edge for quite some time in the whole area of total cost of care management. I would encourage you to go to their website, because they are sharing openly all their proprietary information on the management of total cost of care. They've had some very remarkable results, and it's really fundamental to their strategy. If you sit down and have a sincere discussion with any Health Partners leader about their strategy, it is all about population health management of populations over time with a focus of total costs of care. Service lines, clinical service lines, will not fit neatly into the organizational designs we will be teaching you in your program. They don't lend themselves well to vertical and horizontal lines and perpendicular intersections. They are messier by definition. You will often see clinical service lines headed by a dyadic partnership of a physician lead and a non-physician lead, and those two people will be managing the delivery of that service line and overseeing that delivery of that service line over sites and across sites. So this is frustrating. It's frustrating to a number of classically trained hospital administrators who will, I had one of them say, you know, when we implement this clinical service line thing, it looks like I'm just a hotel manager here because everybody else is managing the clinical services that run through my site. The other important part about clinical service line management, especially in integrated systems, is most of the care is delivered on an outpatient basis. And again, for those of you in my class, we talk about this a lot, that when you look at the anatomy of the revenue structure or the anatomy of the services of real integrated systems and clinical service lines, you will find that most of the health care is delivered on an outpatient basis. In fact, when you look at large integrated systems of $1 billion or more in operating revenue, actually somewhere around 26 to 28% of the revenue base is inpatient. The rest of it is an outpatient business. Certain clinical service lines lend themselves even greater to an emphasis on outpatient care. Cancer care, for example, is largely an outpatient business. Orthopedic surgery now is largely an outpatient business. Upwards of 2/3 of all orthopedic surgeries are done on an outpatient basis. So if you think about clinical service lines, they extend through and across sites over great geographies sometimes. They are largely an outpatient business, and they are not managed per se by site. They're managed horizontally across, usually by a physician and a non-physician who has an opportunity to oversee the delivery of that service line across sites. For our full-time residential students, it is often the case that about 3 years or 4 years after graduation, I'll get a call and I'll hear two things. One, now I understand why you talk so much about that integrated service line stuff, but I was just offered a job. And that job is to pair up with a physician and co-direct a clinical service line across our system. What do you think? My typical response is take that job and don't look back, because you will find a great opportunity, but it doesn't follow the neat and clean diagrammatic approach to organizational design. You will be looking for the perpendicular lines and the reporting relationships, and they won't be as clean and neat as you might expect them to be. David?
You're talking about how the service lines aren't as clean and neat, and so they're defined more of the services that are offered rather than the actual diseases that they're treating. And so, for instance, a given radiologist might be part of the cardiology service line and the orthopedic service line because both of them need imaging.
Yes. Yes, when you take a look at a clinical service line, and that's a good point, David. When you look at a clinical service line, there's a lot of support services that are common across. For example, most clinical service lines, virtually all clinical service lines, will have an imaging component to them. So you're likely to have radiologists involved, except in orthopedics, where most orthopedists would rather read their own films, but that's a whole other discussion. But when you look at the sort of the common denominators of clinical service lines, most, if not all, will have certainly lab. They'll have imaging diagnostics. They'll have a surgical. Most of them will have a surgical component. And then you'll have a pharmacy, and you'll have a variety of support services along the way. But if you think about it from the patient's perspective, which I'd like you to do because this is part of the why, it makes sense from a patient's perspective. I really don't care what location I'm at. I'm being cared for, I think, by a team of people across multiple sites with subspecialty capabilities that I or my family need. And if I'm the patient or I'm the patient's family, I don't need to spend time worrying about site. I need to spend time being concerned with how the continuum of care is managed. Whereas for years, those of us managing healthcare services were more concerned about site and location than service lines across time and across sites. So it's a fundamental shift in thinking for many, including clinicians, by the way. This is not just confusing for management folk. So the methods for supporting services are, to the greatest extent possible, standardized per site, which again, from the patient's perspective, should make a whole lot of sense. I ought to be able to go to any site, and I ought to be seen as somebody that is known. I know I've talked a number of times. My wife's had some very serious healthcare issues, and over the last several years, she's cared for by an integrated system, and irrespective of site, they know her. They have an electronic health record. They call up her record, they know the team involved, they know the care she's received, and that provides a real sense of comfort. And I've told several of you there was one time in particular where she was referred out of the system. And her first question was, should I be worried that I'm leaving the system? What does that question tell you?
She's not thinking about leaving a position, she's thinking about the system.
That's exactly right. She will say, I have a number of physicians that care for me, but there are other professionals as well, and I trust the system. The system has delivered for me. It's not an individual physician, as you suggest. And that tells you that they've done a good job, in my opinion, of delivering on a brand promise through, over time, over a number of years, getting care from a number of service sites within a system. That, in my opinion, is an example of a successful clinical service line strategy from a patient's perspective and a family member's perspective. The health system can produce a unified set of financials. For those of you that are more inclined to the accounting and the financial side, clinical service lines drive classically trained financial folks nuts. Because essentially what you have to do is you have to be able to do both site of service and service line accounting at the same time. So you will have typically the classic sort of site accounting, the revenue accounting, the services accounting, and you will have the accounting of a service line across sites as well. So the finance department or the accounting department, and not so much the billing department, but the accounting department and the finance department have to figure out how to create a usable financial accounting across sites, while at the same time focusing on sort of the traditional site accounting strategies and methods. Most of the time they'll do that based upon direct revenue and direct cost structures, which I won't get into this evening. But just understand that the management reporting, the accounting, the revenue accounting, and the expense accounting is a little more murky for a clinical service line, and you've got to be able to deal with that within your health system. So the service line capital assets are also accounted. So if you're in the cancer business or if you're in the cardiovascular business, you've got a lot of expensive assets. You've got operating rooms, you've got cath labs, you've got MRIs, you've got CT scanners. You've got all sorts of expendable assets on a compressed depreciation curve, meaning their useful life diminishes faster every day. And so as David was implying, or at least I think he was implying, not only do you have imaging services, but you got capital assets spread all over that the service line uses. So patients may pass through the imaging department at several sites. They may pass through the procedures areas in several sites. The assets are immaterial. The clinical assets are pretty much immaterial to the patient. They don't care. They just need to know it's there, it works, and it's just simply a tool the clinicians use. But you're still forced to do capital asset accounting as you normally would under established accounting procedures. The health system can contract this service line as a carve-out. One of the major concerns of costs in the Twin Cities is spine care. So health systems or purchasers, employers, insurers have been trying to modulate and moderate the costs of spine care. So you'll see a number of health systems using their clinical service lines in carve-out strategies. Carve-out strategies. What's an example of a carve-out strategy? And don't say surgery, that would be too easy.
Mental health.
Pardon me?
Mental health.
Mental health would be a carve-out strategy, exactly. Where a purchaser would say, look, you have better total cost of care management, you have a better array of services, we're going to carve out mental health and we'll contract to you for that. When you look at cancer care, it's kind of hard to leave out male, although many health insurers are trying because of price. And so you'll see health systems go to purchasers, whether they're private purchasers, commercial insurers, or self-insured employers, with carve-out strategies based on service lines, hearts, cancer care, orthopedics, those kind of carve-outs.
Dr. Zismer?
Yeah.
Before you go on from that,
Sure.
I'm kind of curious, and I had done my residency at an institution that had service lines, and beyond the financial and accounting components, it was difficult looking just at quality data and even HR when they were trying to collect data, where they would count people. So radiology, they were very concerned, do we double count them? Do we just leave them in their primary? And how do we differentiate that? Is there a standard that's kind of been set or would be recommended for organizations?
Good observation, and the answer to your question, unfortunately, is no, because that's what happens. You did, and that's where the patient care strategy clashes with the traditional methods of operations and finance and accounting, honestly, because you do run into double counting. Well, I've got 10 FTEs in the MRI center, and they're doing MRI cases for cardiology, and they're doing from neurovascular, and they're doing them for somebody else. How do we count them?
Well, and I'm curious if, especially quality data now, since it's getting so popular and a little more transparent, is if they're going to set criteria for you have to count everybody every time, or you only are going to be counting, because you can really change your numbers if you double count or you only count singles.
Yes. The quality data, however, for clinical service lines is usually focused on clinical outcomes. So either you've got the clinical outcomes or you don't. Now, to your point, when you get into the total cost of care question, then you're starting to have to attribute and allocate units of cost, for example. And that starts to be confusing as well. But therein lies one of the challenges, but the opportunities going forward for you, if you can figure out models to do that and do that practically and effectively. And I will absolutely guarantee you will have arguments with those in accounting. But the fact is, if you're designing the service for the patient across time, across space, across locations, that should be the least of your problems. The quality issues, though, as you suggest, are clinical outcomes. They're typically pretty hard data that we're focusing on. You're welcome. The financial incentives for providers treating patients within a clinical category are consistent and harmonized across sites. This is a real challenge, and one of the interesting challenges right now is physician compensation. When you look across many of the systems in the United States, especially the more integrated systems, those that have, I would say, less maturity under their belt, they tend to pay production-oriented, they tend to have a production-oriented compensation system. The unit of measure is typically a work relative value unit. A work relative value unit's a standardized unit of provider effort. It's the same across the United States. And many health systems have been paying physicians and some other licensed providers as a product of how many RVUs did you generate times an internal value of an RVU, and that's your number and that's your compensation. So if you're a cardiologist and you did 10,000 work relative value units and we pay you $50 per unit, your cash compensation is going to be $500,000 this year. That's easy, even I can do that arithmetic. Now as we're moving into total cost of care management, and as we're seeing in a reforming healthcare marketplace, as health systems are starting to take on more financial risk as strategy, we're starting to see those production-based compensation systems butt up against the incentives of total cost of care management. So one of the challenges out there, and if for those of you, some of you I'm sure saw it already, but a major challenge in clinical service line management is how do we pay providers? We're not just in the business anymore of ginning up units of service. We're not simply in the business of creating more work relative value units. And this is probably the guts of the challenge. The guts of the challenge is, in the past, the definition of physician productivity was easy. It was how many units did you create. Now it might be how much cost did I save. So there's been this time of production, definition of production was easy. You did 5,000 or 10,000 work relative value units. We gave you some internal rate per. That defined productivity. Now where are we? We're in a marketplace for clinical service lines where people want to compensate health systems for value. By definition, the health systems want to compensate the people that work for them based on value. It's starting to turn the traditional compensation systems upside down. You've probably heard this from a number of the health organizations that you've been associated with, and that is we need to find a new model of paying physicians and other providers. And that's easier said than done out there right now. So you're going to look for the perfect compensation plan. Somebody's going to ask you to go find it. It doesn't exist. At least I haven't found it yet. A lot of the health systems that have been accustomed to paying providers or physicians by salary are probably better positioned right now. Mayo has been a salary-based organization. Cleveland Clinic has been a salary-based organization. That is the minority out there, by the way. The majority of health systems, integrated health systems in the United States, pay physicians and providers based upon units produced, how many RVUs. And again, that's going to fly in the face of the ability to make clinical service lines work, as I said, across time, across distances, across sites. So that's going to be a challenge going forward. And from a personnel perspective, and I don't mean this pejoratively, I mean this very respectfully, clinical people attached, clinicians especially, and clinical support staff, and even non-clinical support staff, have to be relatively interchangeable across sites. You can't customize a lot of job descriptions per site. Everything won't be standardized, but a tech type or a physician type or another provider should be able to move through the system across the service line and know what the job is. In fact, the Avera Health system, which I think has done some extraordinarily impressive things, now across their rural emergency departments, even has the interior standardized. They have the same cabinetry, the same drawers, all the drawers are stacked the same. So if a physician in a critical access hospital out 70 miles from Mitchell, South Dakota, calls into Sioux Falls and says, I've got a patient in the emergency room, they flip on the video consultation service. The emergency physician in Sioux Falls actually visualizes the patient, talks to the provider and says, here's what we're going to do, and the next piece of instrumentation you need is in the third cabinet, fourth drawer down. So when you look at some of the service lines for Avera, for example, they started with behavioral health, they've moved into emergency services, they've moved into radiology services, they're moving into women's services, and they'll be going to orthopedics sooner rather than later. So the clinical staff have to be trained across sites. So those are some of the characteristics. But once you do this, and here's where I want you to start to appreciate the why. Once you do this and make it known to the marketplace, you are making a brand promise. People will start to trust that brand. They will trust that that brand has a consistency of behavior. They will trust that that brand has a consistency of quality. And they will trust that that brand provides a team to work with patients over different sites. And patients will be able to figure out whether you're, well, I hope they'll be able to figure out sooner rather than later whether your health system is actually delivering on that brand promise. Mayo has gone through that in the last few years. Mayo, for about a decade, acquired a number of, community hospitals and clinics around the country within about a 125-mile radius of Rochester. That was the Mayo Health System. That wasn't Mayo. That was the Mayo Health System. Mayo decided not so long ago that, frankly, that's irrelevant to the marketplace. When the physicians have a Mayo lab coat on, As far as the patient's concerned, it's Mayo. It's not a different health system. It doesn't matter how they do their accounting. It doesn't matter what they think about this in quotes, extraneous system. To the patient, and the facing of Mayo says, we're still Mayo. So they've said, we can't have two Mayos. That's not what the market expects. That's not the brand or the brand promise we're making out there, and we've got to do something about that. So the rationale for this, clinical service lines can provide an advantage if done well. Efficiencies can accrue to the health system, which we'll talk about. Highly trained professionals are more substitutable across sites. You have a higher potential for delivering a real interprofessional team approach. Interestingly, we're just finishing up some work with MedPAC on that. David's been involved with that. Dr. Christensen's been involved with that. And what we're finding, not so surprisingly, is there really aren't standardized evidence-based approaches to interprofessional team care out there. That's one of I think the next best frontiers for clinical service line development and management, the real application of interprofessional teams. Some specialties do that better. Our study so far shows that primary care doesn't do that effectively. That tends to be physicians and non-physicians doing a lot of the same thing. Some of the specialties, the interventional specialties, seem to be doing better with that. Surgeries, surgical subspecialties, and others. But one of the next frontiers for you folks to think about is this notion of the application of highly effective interprofessional teams to clinical service lines across sites. Why? Some of the obvious reasons are highly trained healthcare professionals are going to be in short supply and high demand for the foreseeable future. But if you took a look at our study and looked at how primary care was developed in at least or delivered in some sites, at least one site, you would draw the conclusion we probably have enough, if not too many, primary care physicians, because we had nurse practitioners doing about 88% of the work done by the physicians, and the nurse practitioners was the same. In fact, in the study, one of the physicians said, well, I don't know why the payers don't pay the same amount for nurse practitioners as they do physicians, because they're doing the same work as we are. What he didn't realize was what he said, because the other side of that coin could be, well, maybe we're paying the physicians too much in that model. But coming back to the whole notion of clinical service lines, interprofessional team care, big challenge going forward for a variety of reasons. Telecare becomes viable and more effective. Avera Health System, for example, has been a leader in telecare, whether it be emergency services, tele-intensive care services, tele-subspecialty consultation services. We're going to see, I think, as clinical service lines become more prominent, the strategies become standardized across sites, the application of telemedicine is going to become a lot more effective. A little bit of a side trip on that, not exactly telecare, but I think an extraordinarily impressive innovation, Virtuel for health partners. Anybody encountered Virtuel, used Virtuel? Everybody know what Virtuel is? What is Virtuel? Who can tell the group what Virtuel is? Yes?
It's an online tool that you can go onto, and if you have like a range of, I think it's 20 diseases, or not diseases, but things like a sinus infection or something, a nurse practitioner, you go through a kind of, I don't know, slides, kind of a survey saying what you have, and then a nurse practitioner can diagnose you and give you a prescription. It's
actually, as you suggest, it's a real online diagnosis treatment service. First year, 50,000 visits. They're scaling up for 200,000 visits a year. Another extension of a primary care service line. Quality outcomes, safety, and value are more easily defined and presumably evaluated across service lines, that's debatable. So when you think about this, and you think about this whole notion of clinical service lines, what are some of the challenges? It does not fit well with sort of the classic picture of community healthcare delivery. It doesn't. It doesn't fit with the philosophy of, well, how you provide healthcare in your community is good enough for us. So you must know how to do it best. So despite the fact that you joined our system, we'll leave you alone and you provide healthcare the way you'd like. Just make your 4% bottom line, send a part of that to the corporate office, and everybody will be happy. Not the case for clinical service lines. So what are the challenges? Cookbook medicine. We'll hear from physicians and other providers, well, I didn't go to medical school and I didn't go to training for somebody to tell me how to do this kind of stuff. It is not cookbook medicine. It is a group of physicians and other licensed providers getting together in a system and deciding how they're going to deliver care in a much more rational, reasonable, standardized fashion across the health system. So that's just a red herring, that, well, this is just cookbook medicine, and see, I knew somebody in an administrative office is eventually going to tell me how to practice medicine. It's not what it is. Again, and I'm guilty of this, having been involved in putting health systems together. You join our health system, and however you want to provide health care is okay with us because everybody knows health care is local. Well, really, is health care really local? Do cancer diagnoses differ dramatically across sites? If I have pancreatic cancer in California, is it that much different than pancreatic cancer in Minneapolis? So, and I don't think that the patients see it that way. So we had a different kind of brand promise before, and as I've emphasized here so far, once you're in the clinical service line strategy business, you've really shifted your brand promise on the axis in a fundamental way. It does not, as I said, lend itself well to the traditional classical kinds of organizational management theory and structures that you're going to learn here. It's much more of a matrix-like approach. You've got to be able, as I said, to manage a business. And it may be a business, big business. It may be a $100 million cardiac service line that's delivered across 20 sites in your health system. These are not typically small businesses. So you've got to be able to understand that you're managing both by site and across site. Your operations reporting has to be conducive to that. Your accounting has to be conducive to that. Your scorecards, your performance scorecards have to be conducive to that. So as I said, sometimes I've seen CEOs very resistant to this, and I understand it. There's a good reason for it. And that really was summed up by the CEO that said to me, I guess I'm just a hotel manager now. I used to be able to really run something here and have physicians and other people reporting to me, but I'm just kind of one of the sites, and these clinical services are running through them. A little dramatic, but you understand the point. And I understood the point and sort of the psychological distress that this CEO was going through, facing this fundamental shift in how services would be provided, in this case, in his organization. Now, you'll see physicians sometimes be resistant of this as well. And they'll say, well, you know, wait a minute. I'm not sure I want to have my clinical care overseen by a team of other clinicians. I kind of like this idea of kind of doing my own thing in quotes, my own hospital. And I know the hospital's part of a system, and I get all that. But nobody to this point has really bothered me here. And now all of a sudden somebody's bombarding me with protocols and standards, and we got to get together for peer review, and I got to report outcomes. And I'm not sure I like this idea so much either. So it can be extraordinarily disruptive to cultures, and it can be extraordinarily disruptive to the culture of an organization as it relates to the management history and approach of the organization. So, you know, what's the case in point? I made the case already for Mayo. Mayo had a strategy of acquiring regional hospitals and medical groups. They did it in Wisconsin. They did it in Albert Lea. They did it in Austin, Minnesota. They've done it a number of places. They did it in La Crosse, Wisconsin. And they had Mayo, the big M, and then they had kind of Mayo Light, which was everything else. And they talked about it like that in the organization. That, well, that's the health system. It's not really Mayo, it's the Mayo Health System. Well, you know, when you walk into your doctor's office in Austin, Minnesota, and the lab coat says Mayo Health System, all I need to see is the Mayo part of it, and I should be able to get it. I shouldn't have to ask too many questions about, well, how does that really differ, the system from Mayo, and why don't you explain that to me? That's not the promise that's being implied. So Mayo has gone through this as well. So why are these effective clinical service lines important for the road ahead? Well, we talked a little bit about third-party contracting. The ability to be able to manage total costs of care for a particular clinical population and take financial risk for it, irrespective of where the people get care in the system. If I'm the insurer or if I'm a self-insured employer, I shouldn't have to pay attention to your site stuff or all your little arguments of whose territory is whose. That's not what I'm buying. I'm buying a system of care. So you'll see that the more, what I believe to be the more sophisticated integrated systems with service line strategies are using that as strategy, because many of them know that the more traditionally organized health systems can't pull it off. So they are going to take on financial risk. They are bringing their clinical service lines forward. You can presumably better manage not only the total cost of care, but still the production costs are important, the unit costs. You'll hear a number of health system executives these days say, well, we got to take X percentage out of our cost structure. Usually when they talk like that, they're talking about unit costs per event, not necessarily total costs of care. You have an ability to deliver consistent quality and safety across sites within the system. Presumably you have a competitive edge. And hopefully, and this again gets to the why, you're doing a better job of delivering on a promise to your patients. Again, you're going to run into challenges, or health systems are running into challenges with the strategies because, you know, frankly, we told you if you were the hospital CEO or the lead physician, we kind of told you that you're going to be able to run your own shop. Well, we actually believed that when we told it to you. But stuff has changed, and that's what happens. There's a real shortage out there of clinical leaders, especially physicians, that have sufficient training in management. That's an opportunity. That's an opportunity for non-physician leaders of clinical service lines out there. And frankly, this is such a nascent discipline that it's tough to find best practices. You know, I'll have students from class, whether it's our executive students or our residential students, will say, well, you know, I went to the literature and I didn't find very much about this. You know, you wrote a couple of articles on this and they weren't all that great, frankly, but the fact is there's not much in the literature on this, and there really isn't much in the literature on this. And there's a reason for that, because it hasn't been around that long. As health systems integrate and they still have some, in quotes, independent physicians, they're frankly concerned about scaring them off. They'll go to my competitor. They'll take their patients somewhere else. That's going to be a real threat for a while in the marketplace, but that threat is shutting down out there. Some will say, you know, my competition isn't doing it, so why should I rock the boat? Frankly, I'm always in favor of a chase strategy. A chase strategy being I'd rather be out front and have folks chasing and see if they can keep up, rather than wait for my competitor to make a move, which I don't think is a very sound leadership, frankly. So what happens if health systems don't do this? Well, it depends on the markets and where competition is. It depends upon your strategy. If you're going to come forward with a brand, a health system brand, and a brand promise, then I think you better be delivering on clinical service lines strategies as we talked. And I think it's frankly going to be better in attracting future talent. Since this talk is oftentimes given to health systems, there's and executives and physicians, is sort of little tests I give. This would be one of those tests. If my wife has heart disease, what is the likelihood that she will be treated consistently across sites in your health system? Or are we going to run the risk of the physician we get or the hospital we get is the one we get? Do you have can I expect my wife's heart disease to be cared for and my wife to be cared for in a consistent way across your system, irrespective of sites we visit? Can you promise me that? David?
You mentioned earlier an issue that could arise in this is if you have the independent physician as opposed to all the employed physicians.
Mm-hmm.
Have you seen effective clinical service lines with independent physician groups?
I have. And frankly, that's a reality in a lot of health systems these days where the clinical service line effectiveness doesn't necessarily depend on the employment model. But the physicians who are, in quotes, independent, whether they be in one group or several small groups, have to buy into the philosophy, they have to buy into the culture, they have to buy into those characteristics we talked about. It is possible, it's being done, and it's being done effectively by a number of organizations. Tends to be easier if you kind of get your paycheck from the same place, but not essential. Not essential. Yes?
I have a question too. I'm thinking about the senior vice presidents from the health systems that I worked for this summer. And how do those senior vice presidents who are in charge of hospitals and the insurance component and the medical group, how do they mobilize their respective entities into a separate but still a separate and improved service line strategy like this?
Very good question. You have to start with the assumption that the care will be better, and it'll be better demonstrably, and you need to look at the gaps you have in your performance relative to what would be your ideal or best practices. So oftentimes, the motivator for moving on a clinical service line is the gaps, that we should be here, but we're here, and we could be doing better here, but we're not. And so when you really stack up the clinical indicators that count, the total cost of care indicators that count, and the cost per case issues and the performance operationally, many times it will lead you to a clinical service line based on the need for better results. And it starts there. Then it's a very good question. Then it oftentimes moves to, okay, what would be our brand promise if we did want to move the needle in all these areas? Okay, now how does form follow function? Where are the fundamental gaps in how, or the fundamental challenges in how we deliver care that's causing us not to be able to achieve the outcomes that we think are best for our patients, and best in the industry, and best of class among our competitors? Sure, sure.
Some of the senior vice presidents were physicians themselves, and now they're physician administrators. Does that then fall on them to have buy-in first, and then are they the key messengers to then carry that forward, or is that something that can be equally distributed among non-clinical and clinical administrators?
It can be both of that. I don't think at that point it matters. You just have to buy into it at an organizational level, and what your training is important, but not the driver. The related issue, would qualified physicians across the system review my wife's case and conclude we are consistent in our approach based on known clinical best practices? You know, it's fascinating when you look at health systems, and this is a sort of a hobby horse I've been on for a while. When you look at hospitals, health systems think of the concept of scale, achieving scale more on a corporate level, but not where care is really delivered. When you look at the point of care delivery, the point in which care is really manufactured and delivered, health care is still pretty much a trade guild out there, meaning I was trained to do it, I will do it the way I was trained to do it, the next patient that's presented to me will receive it the way I know how to do it or I prefer to do it. It's much more of a trade guild at the point of manufacturing. And when I use the term manufacturing, I do not mean that as a pejorative term. That is the point in time where professionals get together with patients and create an encounter and create a unit of care. We're still pretty much, to a great degree, in my opinion, a trade guild when it comes to that. Our preventive, again, we're still on the quiz. Are preventive care paths known and accepted consistently across your system? Can I, patient or family member, be assured that the incentives that drive providers across sites are sufficiently the same such that they are not going to be driven by how they get paid? Healthcare is largely still an industry where supply creates demand. So when you take a look at all sorts of studies on the use of imaging, the reason imaging studies are done and that there are differences is because they can be done. You know, here's a little quiz for you. Which state in the United States has the lowest number of back surgeries per capita? The answer is Hawaii. Why? Why? I hear oftentimes, well, it must be genetics, it must be lifestyle. No, it's because they have the fewest number of back surgeons per capita. So when you have supply, it tends to get used. I would hope that as I'm bringing my wife to your organization, the next test isn't driven by who owns the machine or who gets paid for turning the crank on that particular machine. I would hope. Can I expect that evidence-based best practices have been imported into my wife's care plan and you don't simply let everybody do it the way they do it because that's the way you've always done it? So let's move into sort of some more of the survey results. And this was about 40 health systems. I think I said 47. It was about 40. Service line performance direction, evaluation, management is centralized under a leadership team. Now that leadership team might not be anchored to a site. In fact, they're probably not anchored to a site. They're part of the service line, and they need to move across sites, which I said is much more of a matrix approach. It isn't neat, it isn't clean, it is confusing, but it provides ostensibly a better product. Leaders report higher up into organizations. Generally what you're going to find, and this is not just simply isolated to clinical service line organizations, as health systems get more integrated, physicians, hospitals, and other providers coming under the same umbrella, organizationally they tend to flatten out. There are fewer layers between the actual care delivery and the top. You will tend to see in clinical service line structures that the folks that run the service lines tend to report higher up in the organization. There are less layers between the clinical service line leaders and the CEO, for example. So now you probably know when we have students 3 or 4 years out of the residential program say, you know, I got this job offer to be co-director of this service line, should I take it? Yes. It'll be confusing, it won't be easy to figure out, you'll be reporting higher up in the organization, it'll be a faster path to success, at least my opinion. Clinical services privileging is controlled by the leadership team. What might be an example of that? Here's an example of that. At Abbott Northwestern Hospital, the interventional cardiologist set the privileging criteria for interventions at about, I think it was about 75 procedures above that recommended by the American College of Cardiology. Why? They said, we want to have a higher bar. This isn't simply a minimum requirement. We believe that the more you do, the better you get. So you'll tend to see, and this starts to drive the traditional medical staff nuts, because the clinical service line privileging starts to get controlled across the health system. You can't go from one hospital to the next and find major variations in clinical privileging criteria. It interestingly has caused all sorts of consternation, some of which has hit the courts. Those of you in my class got the Avera case results. The independent medical staff sued the hospital because they thought it was getting favored, or the employed physicians were getting favored treatment. The court found on two very interesting results. One, the medical staff has no standing to be sued or to bring suit. It is not a recognized body, at least in the court, and the local court and the appellate court. Secondly, which surprised me, this surprised me, the privileging and the credentialing process does not constitute a contract between physicians and the hospital. Now, I could have argued that because the fundamental substance of a contract is the exchange of value between two parties. You could argue that that is the case. Very interesting findings. The reason they're pertinent to what we're talking about this evening is that when you look at clinical service lines, the concept of privileging starts to be extended across sites from site to site versus having it a site-determined process. Interesting, which I think is going to raise a lot more legal issues over time. Yeah.
Did I hear you correctly a few minutes ago when you said that it was Abbott Northwestern that wanted to raise their bar? Because I would have expected, since they were part of the Allina system, that all of the Allina hospitals would have done so.
Actually, when you take a look at cardiovascular services at Allina right now, it is not a clinical service line extended across sites. Each major heart center, Abbott, United, and Mercy, for example, operates from different cardiovascular groups. I know they share knowledge across sites, but it's not one group and one unified service line across sites.
Is that consistent for the other service lines as well?
For Allina?
Yeah.
Yeah, pretty much. Pretty much. Now, it's not that they haven't tried it. I used to be the chief operating officer of the Minneapolis Heart Institute. We tried it 15 years ago.
Do you know what was the cause for not being successful?
My opinion is they haven't been able to do it yet because still they operate from very much a hospital-centric environment. On the other hand, you'll have the Allina Medical Group, which is 800 physicians across sites that do, I think, a much better job of that. I think what Allina will do over time, my opinion, is they'll take some of these major clinical service lines, and I know right now they're trying to connect protocols, they're trying to connect evidence-based best practices across sites. So they've made, I think, some very successful inroads into that, but I think they're sort of a ways away from sort of the ideal we're talking about tonight. Certainly on the path, certainly on that path. Unified scorecard across sites, whether that be clinical, operational, financial, and continuous and rapid cycle importation of evidence-based best practices, and this isn't easy stuff. And I don't remember the citation, perhaps maybe some of you in class do, but there's a study, it was either in New England Journal of Medicine or JAMA or some other reputable publication. And the question was, how long does it take for readily accepted evidence-based best practices to find their way to common practice in the medical profession? Anybody know that article and the result? It was about 17 years. Should it take that long? And one could argue, no, but it is what it is. So what are some of these clinical service lines that are being pursued? Cardiovascular, still a big deal. Cancer care, women's health, diabetic care, preventive care for both adults and pediatrics, orthopedics, behavioral health, rehabilitative care, spine care. So you will see a lot of these programs. Heart has pretty much led the way. I still believe there's 1,000 top 100 heart hospitals in the United States, because no matter where I go, there's every hospital A has a heart hospital, B it's top 100, and there's got to be 1,000 of them out there. So in summary, clinical service line strategies, if they're for us, meaning your organization, then there's ways of doing it. And if they're not for you, then what's your strategy? Then what are you going to be out there in a market that wants you to take risk, where you have to think about managing populations over geographies, and all the other stuff we're gonna talk about over this operations and strategy seminar series. Does this make sense to you? So this is the table setter. So what we're going to do the rest of the academic year is every month we're going to build on this theme. We're going to talk about emergency care, for example, as a clinical service line. One of our graduates runs a very large emergency care company that contracts with a lot of health systems. He's going to come in and talk about that. We're going to talk about that from a perspective of rehabilitative care. We're going to talk about supply chain management in clinical service lines. So what we're going to do now forward once a month is build on this theme. What I wanted to do for you tonight is sort of set the stage. Why does it make sense? What are folks doing? How they're thinking about it. Questions? Comments? Sound like a good idea? Sound like a bad idea? Yes.
I have one additional kind of
Sure. Sure.
I'd like your opinion on. I think a lot of focus right now has also been on the branding that hospitals can do, or health systems, can do to get people to change their mindset from physician-focused to now system-focused. Do you also think that a contributing factor could just be generational differences? Since I know a lot of seniors still think of like their one physician and that's who they're going to see for the rest of their days, whereas our generation doesn't consistently have that as much.
You know, I think that's a good fundamental question.
Some of the old people are not fixated.
I would suggest that it may not be generational. It's because the design of the system has caused people to think a certain way. So, you know, when you think about people my age and older that go to Mayo, you never hear people say, well, I'm going to drive to Rochester to see Dr. Zismer. I'm going to drive to Rochester to do what? Go to Mayo.
Okay. But I'm thinking more at the younger group. Do you think that they're seeing that same reasoning because the health system has done that, or just because it's already changed? I guess it's the chicken or the egg question.
I think it is. I think we have a market that behaves because that's the way the system was designed and served the market. As the market consolidates, and the market is clearly consolidating out there, we will be at a point where the system, it's an opinion, right? The system elevates itself above the value of the individual physician. The value of the team starts to become more important. People connect by computer. I can go on and call up my chart from my healthcare provider. It'll be an interesting transition to watch, but I'm not convinced it's generational.
I've heard other groups, part of how they're encouraging this is they're not giving you one specific physician, but they're kind of intentionally rotating you every so often. So even if you come in for an annual, they'll give you a different provider in the same group.
I think what we'll see, I don't think we'll see that, but I do think we will see people identifying with interprofessional teams. There's a team. You know, I see my physician once in a while, but I know he has a team of people that I interact with.
So you think there will still be the my physician mentality?
I think there'll be some of that, but Healthcare, healthcare's diseases are complex. If, as they teach you in medical school, you can have ticks and fleas at the same time, meaning two things or more than two things can be wrong with you. And if I have a complex chronic disease, who's my doctor? I might have a primary care physician, I might have a cardiologist, I might have a diabetologist, I might have a vascular physician, and if they're all part of the same team and in the same organization and they share the same record, all of a sudden I can start to feel the value of the team if done well. And I think that's going to probably, and a speculation on my part, create probably more patient loyalty and stickiness to a system than many other strategies will. Again, an opinion. So, yeah, yes. And welcome, by the way. Good to see you.
Yeah, some of the rewards in terms of total cost of care today have the attribution methodology in it where you're supposed to stay with a provider versus going to different providers, and that because if you stay with one provider, they're thinking that your cost over time is going to decrease versus if you're going to multiple providers and you're all doing different things. And so that's what we see a lot today, especially with health plans.
What's the fundamental vulnerability in the attribution model?
That someone is going to
Leave.
leave and go to somewhere
Yeah,
else.
so if I can't be held by contract or financial incentives, which I think we're most assuredly going to see more narrow network strategies. I think that's a given. But to your point, which is well taken. In an attribution model, in a pure attribution model, by definition, the vulnerability is I can leave. So it behooves the health system to create a sense of loyalty and stickiness there, so I don't want to leave. And if I start to trust the system, as my wife has, the probability that she's going to leave sort of willy-nilly is almost nil, unless the system stops or fails her, rather. Yes?
In clinical service line and sort of brand image, as you spoke about, within an integrated delivery system, obviously, all the different delivery centers are not identical. They're
Correct.
usually acquired over time. They have different types of services. So how does, say, Avera, commits to a women's health clinical service line, but they have really small critical access hospitals that don't have women's health specialists.
Mm-hmm.
How does that clinical service line extend into those spaces? And how does Avera not lose the integrity of their brand image? We have a women's health system, but yet we can't really.
And I think, first of all, it's a good question. I probably should have addressed that more effectively, and I didn't. The issue is, any rational person doesn't believe you'll have everything in every site. You're not going to do heart transplants in critical access hospital. So you have to rationalize services, people, and capital across sites. And you may live in a small community, and I may be your primary care doctor in a small community, but I'm part of the system, and I understand the women's services that we have, and I can't provide all of that to you here, but I'm connected to that. And if you need to get to Sioux Falls for a special diagnostic or test, you're going to go see my partner there because I'm part of this. And we have one electronic medical record that will connect us together. And I'm a small part of it, but I'm still a part of it. And you're still participating in the women's health program. But certain services we're not going to be able to provide out here in the critical access hospital. But I'll make sure you get to those, and I'll make sure I help you do that. When I was with Essentia, we had our main tertiary referral centers in 2 places, but most of our health care was rural. So a good portion of our people didn't get care in the tertiary centers, but they still felt connected because their primary care physicians had one electronic health record. We had teleconsultations, and the patients realized that we're not going to provide everything at every site. But that's part of the art and the science of managing a clinical service line. Good question. If that's it, this was the kickoff session. You'll get some stuff telling you who's coming next, but we're excited about this approach, and I hope it works for you. So thanks for coming this evening.